Nice. Good morning, good afternoon, good evening, everyone. Thank you for joining us from many different time zones around the world. I'm Dr. Mena Ramos. I'm a family physician and co-founder of Global Ultrasound Institute, along with Dr. Kevin Bergman. And if this is your first webinar with GUSI, welcome. We are a community of healthcare practitioners passionate about POCUS. And our mission is to decrease the barriers to POCUS adoption across the continuum of care through education and training, community building, longitudinal mentorship, and software to support workflow reengineering. So today's webinar I've been looking forward to for several months now on POCUS and the patient experience. We've looked at POCUS up until this point from different perspectives across multiple specialties. We looked at administrative barriers, billing and credentialing, quality assurance, and in the effort to build an inclusive POCUS community and culture, which has really been the driving force behind these webinars, I think it's only fitting that we examine POCUS from the patient's perspective and look at the research behind what has been done to really consider the patient and the patient experience. And so I'm really so excited to be joined by this incredible group of physicians and researchers. Kevin, can you take over?
Thanks so much, Mena. Yeah, we're really excited to be here, and we're just so fortunate to have just a truly wonderful panel of clinician researchers and experts. And there have been thousands of studies on POCUS in terms of clinical use cases and its use in medical decision making and sensitivities and specificities, but a very precious few studies focusing on the patient's experience and how they perceive it and what impact it has on them. And that's exactly what these four panelists have been focusing on in their research. So we're just really pleased to have them here, beginning with Dr. Camila Anderson. She's associate professor, senior researcher, and head of the ultrasound group at the Center for General Practice at Aalborg University in Denmark. Dr. Tan-Ping Wong, clinical hospitalist at Weill Cornell Medicine in New York, program director for the POCUS Fellowship, and also co-authored the recent paper on the patient's experience of POCUS in hospitalized patients. Welcome, Tan-Ping. Dr. Josh Overgaard, internal medicine physician practicing at Mayo Clinic in Minnesota, directs the POCUS Education Internal Medicine residence at the Rochester campus, and is also a section chairperson for the International Medicine section, General Internal Medicine. And also Evan Balmuth. He co-authored the recent paper with Dr. Wong and is a fourth-year med student at Weill Cornell Medical College in New York City. So welcome you all. Thank you all so much for being here. And before we jump in with you all, just thought we'd share just a very brief 1-minute video of just one patient relaying his experience of an ultrasound during a recent visit to his primary care physician. So we obtained permission for him to share a story with other practitioners. And here you go.
It just added a level of confidence and confirmation by seeing it visually. When I saw the fluid leaving and the tissue around it getting relieved, in my mind, I saw the pain going away. It almost gave me a visual indication that the fluid represented my pain. And so by withdrawing the fluid and actually seeing it being done, I saw the pain go away. Just using the ultrasound as a tool, not only for an aid for you to do exactly what needed to be done, but also using it as a tool for me as a patient to be able to see what was going on and understand what was happening better, and just seeing the relief through it all.
Great. Well, thank you so much. And with that, I would love to ask you all if you would be willing to just give a brief brief description of your research and your studies. And Camila, hopefully we can start with you.
Yes, thank you so much, Kevin and Mina. I will share my screen with you and try to tell you a little bit about the study we did. Yeah. So I hope you can see my screen now. Yeah. Hopefully it's working. Yeah. So as you know, point-of-care ultrasound is increasingly used across countries and also across healthcare systems. You may know the triple aim framework that is being used to target, but also to evaluate healthcare. As Mina and Kevin said in the beginning, we have been focusing on evaluating population health, clinical outcomes, diagnostic accuracy, but also to see if we can reduce healthcare costs. But less attention has been given to evaluate how patients experience this use of ultrasound. We've been looking into this, and what I want to share with you today is a result of a cohort study we conducted in Danish general practice in office-based clinics in 2018, where we asked 20 GPs to give out a questionnaire to all patients that they examined with ultrasound. The questionnaires were filled out in the waiting room immediately after the consultations, where ultrasound was used as an add-on to usual care. We ended up analyzing questionnaires from 564 patients. So what we found was that 99% of the patients found that ultrasound was integrated as a natural part of the consultation, and 96% of the patients felt that this use of ultrasound was actually not disruptive in the consultation process. And 45% of the patients felt that with the use of ultrasound, their relationship with the doctor actually improved.
We also found, would you be willing to click on that slide? Yeah, we're not seeing the presentation part. It's just on the first. Yeah, it's just on the first.
Oh, stethoscope. I'm so sorry. I'll try to do it one more time. See if it works better.
No problem.
So, do you see it now?
I think it's just the stethoscope. So you could just click on that slide, and that will
I'll do it like this.
Yeah, perfect. Yeah, perfect. Thank you.
So yeah.
Great.
So we also found that ultrasound has a reassuring value, as 92% of the patients felt that they have been more thoroughly examined with the use of ultrasound. And 65% of the patients felt that they had an increased trust in the GP's assessment of their healthcare problem. And 81% of the patients felt that they had a better understanding of their health problem following the use of ultrasound. And 85% of the patients felt that they've been taken more seriously. And 86% of them felt relief and a sense of, they felt more secure following the use of ultrasound. Overall, the patients had a high acceptance of the use of ultrasound. 80% of them felt that this use of ultrasound had a large influence on the care that they received. 95% of the patients felt that ultrasound improved the level of service in primary care. And 94% of the patients felt that ultrasound actually improved the quality in care. And overall, 98% of them felt that it has been a positive experience being examined with ultrasound by their physician. So from this study, we learned that in office-based general practice, it seems that ultrasound aligns with the patient's preferences. And this was not restricted to specific examinations or individual GPs. Ultrasound had a reassuring value for patients, and as a physician, that is important to know that the patients have a high trust in the technology. So we have to communicate the limitations with POCUS to them, so that we make sure that we don't give them a false reassurance. Yeah.
Wonderful. Wonderful. That's thank you so much for that overview. That like really impressive study, and those results are really quite remarkable. And we'll have time to unpack more of those in a minute. Can we turn it over to Tanping and to Evan, and you can talk about the study that was recently published in PLOS on hospitalized patients?
Definitely, I can introduce the idea behind the study. This is our first paper on this, so by no means are Evan and I experts in this field. So to give you a little bit of background, this stemmed from an idea that came out of a conference that one of the beginner learners did. And he did a conference on the placebo effects of technology, and in particular, POCUS. And for the longest time after that, I keep speaking with him about, we need to do a study on this. And then there was an opportunity for an internal grant for students, a very small amount, and we applied for it and we got it. Then we needed someone else to run the study, and hence a fourth-year student who has time. So hence Evan came into it, and then we sort of hash out the ideas of the details of how it was going to be done. So I'm going to let Evan explain a little bit about the methods and the results of our study.
And I'm just going to share my screen. I have a slide as well. Okay. So yeah, really grateful to be here. And so I can describe very briefly the study that I worked on together with Tanping, as well as other colleagues, including one of my fellow medical students at Cornell. Essentially, going into this study, just as a brief background, and I think also as Camila alluded to, we know that there's potential for POCUS to provide what we call socio-emotional benefits for patients. And in our study, we came up with a term called the POCUS positive care effect to describe what we observed as a placebo-like effect of POCUS. However, this hasn't really been documented in depth, especially in inpatient settings, where lots of physicians, at least here at Cornell, had observed anecdotally this kind of placebo-like effect. So we really wanted to evaluate how does this positive effect take shape, and what are the mediating factors, and which patients would be most receptive to this. And so we conducted a mixed methods cross-sectional study focusing on 30 adult patients who were admitted to medicine floors at our hospital in New York City, who were receiving POCUS as part of their routine medical care. And as a mixed method study, this involved pretty much two parts. My fellow medical student, I observed POCUS encounters that were conducted as part of routine care. And then after the POCUS exams, we administered surveys that mostly were composed of Likert style questions, as well as some open-ended questions. And then we did qualitative thematic analysis and kind of basic descriptive statistics and correlation analyses. And to kind of boil down the key results of our study, we saw a lot of concordance between our qualitative and our quantitative results. So some of the most striking findings for me were that for nearly all patients, there was a very large POCUS positive care effect that was really defined by satisfaction with their hospital providers, their overall care in the hospital, and also the perceived efficiency of their care in the hospital. And factors that most facilitated this positive effect were mutual engagement between the patient and their providers, a strong therapeutic alliance with lots of communication. And interestingly, I'm sure we'll talk about the overlap in our findings with Camila, but a major element was actually specifically providing reassurance through ultrasound images. And then We also found that certain patients were more receptive to this positive effect than others. In particular, patients who had perceived that they had received efficient care in their hospital stay already leading up to POCUS, those with lower anxiety levels, and those with less severe illness at the time of the POCUS exam. And so having basically taken a first stab at trying to define this positive care effect and mediating factors, we think that this will lead to future studies that are randomized so that we can better define what we hope will be an optimized form of POCUS called therapeutic POCUS that's essentially adapted to provide a positive care effect. And we hope that a better understanding of these benefits for patients can lead to further development of POCUS usage in inpatient settings and other clinical settings, and above all, to help improve patient well-being in the clinical space.
Wonderful. I know I really enjoyed reading this study as well. Just so important, this research, and really quite remarkable, impressive, the results that you had. So we're going to talk about that a little bit more after we hear from Josh. Josh, can you describe some of the work that you've been doing in this space with patient POCUS and the patient experience at Mayo?
You bet. Yeah. And Kevin, thanks so much for the invitation. I feel very privileged to be here among all these awesome folks. I just, for the record, when I read Camilla's study, which came out a while ago now, I was just it was so nice. It was so, I don't even know what the right word is, refreshing or validating or something in between the two of those. Because I think those of us who do a lot of POCUS, we know this to be true, right? We know that our patients love it, and we know that it's meaningful, and we know that when our patients feel like they're getting good care, they follow our recommendations, right? I mean, I think it would be easy to look at what we're doing and say, this is just kind of soft, meaningless stuff, like it's fluffy, right? It doesn't matter, but I think it does, and I would love to one day, I think future research could show that we can actually impact compliance with this kind of an approach. When people feel like they're listened to and taken seriously and that their doctor is good at what they're doing, they're going to be more likely to follow those recommendations. It stands to reason, remains unproven, but it'll be a good day when that happens. So anyway, so my practice is mostly in the consultative world in Mayo Clinic. So I'm an internist, but I function as not a primary care doctor, not as a hospitalist, but as a consultant. So the folks that come in from out of, kind of what we're known for, I guess, people come in from out of town with unexplained symptoms or, complex serious disease that their local team doesn't have the resources to manage. And so I'll be the person that kind of sees them first when they come here. I get things set up for them for their evaluation. Then as they're going through this, I'm helping to coordinate that, and I put it all together at the end and tie a bow on it and get them back home. We do that for domestic patients. We do that for international patients. And our patients are unique in that they have very high expectations, fairly, because we have an excellent reputation. So they should expect a lot of us. And there were a few of us that were wanting to use POCUS more in our practice, but in our environment, we have to be really careful that what we're doing is well received. And this population is different than a hospitalized population, and it's different than a primary care population. So we just actually adapted Camilla's survey because we thought it was so great, and we conducted a very similar study in that we surveyed our patients after they had a POCUS exam for whatever reason they were in the clinic. We found a reason to do one. It was heart, lungs, vascular, abdominal, whatever the case might be, and then we gave them that survey. The results were very similar. I mean, I guess to boil it down, we haven't published it yet, and only because I'm slow at writing. But if I had, I would love to share graphs with you. But I've been advised I shouldn't overshare it because it could risk our successful publication. But anyway, our results were very similar. They were overwhelmingly positive. Honestly, we surveyed 100 patients. There was really, I think, one person that keyed in a negative response to anything, and it looked more like a process error than an actual truly negative response when you look at the rest of it. So it was overwhelmingly positive. And I think we also solicited comments from our participants in the study, and those also too were just wonderful. They were fun to read because it was like, this was so neat. It was so fun to be a part of, and you could just tell that this created an energy to them or for them in that connection that they had with their doctor. So it was really fun to read that. We were encouraged by it, and obviously now our leadership are like, wow, we should be doing this to everybody. Because it is important. It is important that our patients are satisfied and that they think they're getting good care. It's important that they're getting good care, but it's also important that they recognize that. So that was fun. I also, I think, and this bears out really in Camilla's data too, and I don't want to over sort of interpret it, but I find it interesting the fact that the degree of positivity to how much they appreciated that and how much it changed their confidence in their doctor was more so than how much they thought it affected their treatment, right? Like they're like, I get this probably didn't change much, but it still helped. Like it was valuable to them because they learned more about their body, about their condition, about all these things. And again, this is stuff we know because the patients have told us this, but I think it's really important to have this in the literature. I think it's a really important conversation to have. And I think we should never lose track of the fact that that's why we're here. It is the patient experience that we're here for, right? So yay. And I guess I've probably talked enough. Thanks, Kevin.
Thanks for that, Josh. No, it's all really, really great points. And kind of picking up the thread of what you were saying there, I wanted to ask Camila, Tanping, Evan, what do you think the reason behind the results were? Like maybe Camila, we could start with you. Like, what's your perception and what kind of came out of the data? And as a POCUS practitioner yourself, what do you feel like were the driving forces behind those results that the patients shared?
Yeah, so I think really interesting to hear that we have similar results all over. But I think I probably expected that there would be some differences between different kinds of ultrasound examinations, that some examinations would have a higher patient satisfaction than others, but we didn't find that. And I think that was a bit surprising for me, because when I use ultrasound, I have some examinations where I think wow, this really changed something. And I have other examinations where I'm thinking, yeah, maybe it didn't change so much. It gave me some more knowledge, but it didn't change that much in terms of the patient pathway after my examination. But yeah, the patients were happy regardless of what the GPs used ultrasound for. So I think, yeah, I don't know why that is. And I think that is something that we need to explore more. We need some qualitative studies, and I think Tanping and Evan already started that. And we need some more knowledge and some more patient interviews to know what is actually going on. What is their trust based on? What do they experience when we use this technology? So that we know what's going on also, and we can take that into account when we process information and we communicate about the use of ultrasound. But of course, because we're not doing a full body MRI on the patients, there are some limitations with POCUS, and we have to be sure that they don't have a false reassurance after our examination.
A really, really good point. Tanping, Evan, from your research, any thoughts? So what was kind of some of the driving forces behind the positive results?
Evan, do you want to get started first, and I'll jump in from there?
Sure. Yeah, I think it's a really interesting and important question, why we see that patients really like POCUS and why we think that they're getting additional placebo-like benefits from that. And at least in our study, we don't have a clear-cut answer, but a lot of the rationale that went into the design of our study was based on psychology literature around placebos. And we know that POCUS inherently involves lots of elements of clinical care that are known to lead to placebo effects in other settings. For example, the element of touch in the clinical interaction, the element of spending time together with your clinical provider, and among other factors like sophisticated technology also has been shown to be related to placebo effects. Being able to interact with images that help to explain clinical findings. So these are all inherent parts of POCUS, and this isn't something that we explore, but from my limited clinical experience, I see that in hospital care specifically, a lot of these factors that are important to patients and that yield placebo effects in other settings are especially lacking. There's less time with your provider. There are lots of things going on, many different providers coming in and out. It can be a particularly stressful environment where it's possible that POCUS is kind of addressing those basic needs of patients, kind of where there's more of a void than usual, maybe in other settings, but we'll really need future studies to look more into that why question.
And I agree with what Camilla and Evan has said, and that is the million-dollar question, right? Why is it? And then I think that for us, for POCUS users, which I assume many of you are, if you're on this conference, you believe that this is a good thing that's beyond just obtaining clinical information. And perhaps it's time, perhaps it's really engagement, perhaps it's the touch, and I don't know if we'll ever be able to tease out any of that. And part of the reason that I push for this study is not so much to validate what I believe is right, but to prove to people who are not using POCUS that it's indeed something beyond just time, right? Is it isolated to POCUS that we're finding this positive effect? Or is it that you just need to spend more time in the bedside and you need to engage patients more? And are there other less expensive ways of doing it aside from POCUS? And that is a big part of my impetus to showing that, yes, maybe we may not be able to tease it completely out, but the component of the machine and the technology and the image is a big part of this.
Yeah. Yeah, really, really, really good points. Josh, how about you? What do you think is it underlying?
That was all very well stated.
Yeah.
And I think, you know, honestly, one of the things that's interesting to me, the placebo effect is really interesting to me. And the idea of things being in our heads versus not in our heads is really funny and interesting. And I think about the times, you know, if I remove myself from POCUS, I've had a number of encounters with patients. Apart from that, not using POCUS, where I had enough time to sit and listen to them and had enough time to explain to them what I was thinking and validate their concerns and their experience. And as we walked out of the room, they said, "Oh my gosh, I feel better." And that's a real physiological phenomenon that is the result of the relief of stress. Stress makes pain worse. We know that. So when we spend time with our patients, when we teach our patients, when we counsel our patients, and when we comfort our patients, they should feel better. Otherwise, it's not working. Like, there are understood biological neurochemical mechanisms to explain that response, and I don't think it's just in people's heads as we think of that. So I think it's great. I think we should shoot for placebos when it doesn't have risk. You know, I think one of the folks in the chat raised a really interesting point, and maybe I'm getting ahead of myself, but you know, thinking about false positives is super important. You know, when we talk about placebos, we have to be really mindful and careful about about staying in our scope and about being honest with our patients about what we're doing, right? Like, when I think about patient experience and as it relates to POCUS, yes, that's a great reason to do it, but it's not maybe sufficient, right? I don't just do this to make people feel good. I do it to try to help answer questions, and I daily am careful about, I don't want to be a cowboy. I'm not a radiologist. I'm not a sonographer. I'm not a cardiologist. I'm going to understand what I can do well. I'm going to try to make sure I'm understanding what I do well, and I need to stay within those bounds. But within those bounds of doing good medical care, it's a powerful placebo, whatever that means. And yay, I love it. Let's do it.
all
Yeah.
really awesome points. Minna, maybe you want to bring forward a few comments from the
Absolutely.
chat.
Yeah, we've well, I think Josh kind of addressed this concern about false positives on POCUS leading to potentially additional unnecessary testing that isn't as benign as POCUS, and potential downsides. Another question about, did the research cover and were the results the same in the clinic, hospital versus potentially a remote or home care setting? I think I'm really excited that we have three different research bodies here, because each one of you represents a different aspect along the continuum of care, and to hear that there is a common thread. Anyone want to jump in just to answer that question about different settings, both in the clinic, hospital versus potentially remote or home care, if that was looked at all? Camilla?
Yeah, so all our 20 GPs worked in office-based clinics in primary care. So and we had both practices that were located in cities and in more remote areas, and we didn't see any difference. So for both urban practices and for rural practice, it was the same. The patients were happy. Yeah, so we had a high ceiling effect. All patients were very happy, so it was difficult to see if there were some differences between urban and rural areas.
Did you all, Evan, Tamping, Josh, did you tease out any differences of the patient's context, or Evan, you'd alluded to it, for the level of disease that they had?
Yeah, I can only really speculate because at least in our study, we only looked at hospitalized patients, but based on our finding that there just seemed to be some involvement of the degree of illness severity that could modulate the patient's receptivity to a positive care effect, then that would suggest that maybe in different care settings where that correlate with different degrees of illness severity, yeah, I could imagine there are lots of factors that could affect the degree of benefit or whether patients could benefit. But at the same time, it seems like in these different settings that we've conducted our studies in, that there are common threads that should be the same regardless of the setting. So it would be interesting to compare those directly.
And to just elaborate on some of the things that we found in our study, I think the question that I have is for really sick and unstable patients, right? Patients who may be in the spine unit and ICU, whether we would see any of the positive care. So I question that, and we don't know at this point in time because we have no studies in the area. But you can imagine that may not make much of a difference. I don't know the answer.
Gotcha. I wanted to hear from each of you all about your own personal experiences with POCUS, and what are the main reasons why you incorporate it in your care, and why this is important to you, and why you're passionate about this area. If you could just bring forward, maybe Camilla, if you could start.
Yeah, happy to. Yeah, so I think one of the main reasons why I got into this almost 10 years ago was that I experienced, being in primary care, I experienced collaboration with secondary care that became more and more subspecialized. And also I saw a quick turnover of patients. So when I referred a patient to the hospital, they were quickly returned to me. And then also we have increased burden of elderly patients and more multi-morbid patients. So this really changes our diagnostic ability. We have to be able to do more. We have to be able to take care of more sick people in primary care. And when we refer on to the patients, we have to make sure that we send them on to the right department. So in our referral, we have to be more precise, and our diagnostics have to be more precise. And I see ultrasound as a tool in that way. So it can lead to improved diagnostics in our setting, but it also can lead to more precise referrals. So ultimately, we reduce time to diagnosis and time to treatment. So yeah, that's the main reason why I'm in this. And then it also gives me more professional contentment and job satisfaction. And I think the patient experience and having that positive response to what I'm doing right there in the consultation is a big part of that.
It's interesting.
Yeah. And Ping, how about you?
You know, it's funny how things come into our lives and our careers. I was many years out of residency before I even encountered POCUS. And I learned it because a resident came to me and showed me a POCUS image, and I didn't know what it was. So I work in academic medical centers. So in order for me to stay relevant, I thought I had to learn POCUS. And this is about 8 years ago, and I thought I would just be learning it just to know it. And little do I know that it gave me such a boost in the love and excitement of medicine to be able to see physiology, to be able to use it to teach. And it's taken me to places I never thought imagined. So it's been really, really fun. And from the study with this positive patient care experience, you know, when you first start learning a technology, you just go in and try to get the information that you want, just try to scan. And now I'm much more cognizant that when I enter a room with the machine, I'm entering the room with myself and one additional person, and be very aware that this particular thing that's as big as me has an impact on the patient. And not always positive and not always negative, but just being aware that this is something that I should introduce and be cognizant of how this impacts the patient's experience. But overall, it's been a really great experience.
Wonderful. Wonderful. Evan, how about you? You're early in your medical journey.
Yeah, I was really fortunate to learn POCUS from Tianping as a second-year medical student leading up to the beginning of our study. And because of the timing of that, I was able to incorporate POCUS through a lot of my third-year clinical rotations and in my sub-internship. And to be surrounded by POCUS mentors at Cornell. And so I've already experienced how helpful it can be in clinical decision-making, how it can change management in a lot of different clinical scenarios in the inpatient setting specifically. And so I just think it's a really unique tool with so much potential. I mean, we know the diagnostic benefits are well established and relatively well researched compared to the aspects of the patient experience. But I think it's quite unique that a tool with so much diagnostic potential also has therapeutic potential. And I know the POCUS has been referred to as the stethoscope of the 21st century, which I think is a really interesting and exciting concept that that this is the future of bedside diagnostics. And so, yeah, I'm very fortunate to have started to learn early on and excited to see where it goes through the rest of my training.
Josh, how about you?
Yeah, I guess I was fortunate enough to just have people that I trained under that picked this up really early on. Honestly, when I was in medical school, I was on a rural primary care rotation in the absolute boondocks of Minnesota, and like in the trees in the north with just snow and moose and things and like that. But she went to some CME that one of my preceptors had gone to this CME and heard about POCUS and was like, oh my gosh, this is coming. This is gonna be the next thing. And this is back in 2007. I mean, it was quite a while ago. And this is a primary care doc, and it was really pretty restricted to emergency medicine at that time. But she went and raised money and bought a machine. It was like, Josh, you should learn this, and just turned me loose on it. It was really great, and it was so much fun. But and then throughout my career, I've had I've just wound up with people that could teach me how to do this, and I recognized it as a powerful tool pretty early on. And to me, I like taking care of sick people. I think it's really it's interesting to me. It's gratifying to me, and it is just so obvious the benefit this has. I mean, when I started doing it, we didn't have a lot of evidence, and the argument was more difficult. I think now there's a lot of evidence has come out that meaningful patient-centered outcomes are improved when we use this tool, and it's great to have that. I mean, those of us who were doing it before we knew all of this, we knew it anyway because we could see it, right? When you pick one of these things up in the emergency department or in the ICU, that you needed to know that you couldn't know, you don't have to run too many codes with an ultrasound to recognize the value that it has. But it's nice to see the literature bear that out. But anyway, to me, I was just blown away by how useful it was and how many answers I could get at the time that I needed them when I'm with the patient. I can get them out the door with what they need. They don't have to come back and have other appointments. They don't need to spend a bunch of extra money on imaging. It was just such a better workflow, better for the patient. And I totally agree with Tampang too. Or whoever, maybe it was Camila who said it, but it's fun. I think it's super fun. Mechanical things are enjoyable to me. And so it's really a win all the way around.
That's great. That's wonderful to hear all that. I think a lot of the backdrop of what we're talking about is one word, and that's trust by the patient. And I was curious some of your thoughts on that, and if it was part of your normal POCUS practice and workflow and the study results to how much you share with the patient and how much you involve them in the experience. It's a human thing especially if you're vulnerable and you're sick, you're in a fraught moment, and to be able to feel more confident and to actually see something with your own eyes versus just taking somebody else's word for it, even if it's a respected healthcare practitioner, is just always, just as human beings, just so much more reassuring. Anyway, just curious your thoughts on that, on how much you share, especially, and will any of this research change any of that? Camila?
Yeah, so when I use ultrasound, I always start telling the patients, so why am I doing this? So I'm targeting my point-of-care ultrasound for something, and I'm communicating that to the patients. And then I always tell them that in the beginning, I'm going to be quiet, and I'm going to have the screen turned over to me, and I'll be focused. And then when I've seen what I want to see, I'll turn the screen to them, and I'll communicate to them, what do I see, and how do I interpret this, and how is this going to impact your care? And sometimes if I refer them on to the hospital, I'll ask them to give me their phone, and I'll take a picture of the screen with their phone and give them the phone back, and ask them, when you go to the hospital, show them the picture on your phone. So I try to make it a shared experience, and I try to involve them in my decision making that way.
Bing, how about you? Yeah, Tampang, Josh, or Evan, any thoughts about that? I think you might be muted.
Similar to Camilla, I do use it to my advantage and engaging the patient and letting them be involved in what we're seeing. I think that what I want to share is that sometimes when we see unexpected findings and the patient is seeing it, and of course they probably don't know what they're looking at and how to deal with that in real time. And it's a little bit of a struggle for me to see something unexpected. I have not had the time and the space to process it yet, and not sharing that with them or deciding how much to share that with them. So I think that it's complicated because they're involved in every step of the process. And the easy part is to say that I'm going to use POCUS to my advantage to engage them to the direction that I want them to go. But when unexpected things happen, I haven't figured out completely how to deal with it, and I don't think I'm completely honest in disclosing everything that I am seeing, especially if it's something unexpected and not something that's favorable.
Absolutely. Yeah. Evan, Josh.
Yeah, again, I have limited clinical experience, but speaking from what I learned from our study, we touched a little bit on this topic of trust, and we did find in our qualitative data that when patients seem to have the most benefit, kind of like socio-emotional benefit from POCUS, it tends to be in situations where there is a really deep underlying trust between the patient and their clinician. But since this was a cross-sectional observational study, we didn't really evaluate whether POCUS increases trust or what the directionality of that relationship is. So anecdotally, it seems that POCUS could facilitate trust where there's less underlying trust to begin with. But at the same time, going back to the placebo literature, it seems that trust is important for shaping a patient's mindset into a way that will make them receptive to a placebo effect. So, this isn't always necessary part of using POCUS if it's purely for diagnostic purposes. But if we're talking about kind of this dual function of improving our diagnostics, using it to answer clinical questions, but also improve the patient's well-being and help them have a positive experience, then trust seems to play a really important role. But it definitely needs to be explored in more depth.
Josh, what do you think about that?
Yeah,
Transparency,
for
shared
sure. I mean,
decision making.
sorry, what's that?
Oh, I was just saying that the transparency factor,
Oh,
that's just so radically different from a stethoscope. It's
yeah.
going into your ears that they have no insight into versus this.
I mean, kind of almost to tie the trust together with the experience, I think I feel like the transparency is really key to that in my mind, I guess in my experience. I talk them through the entire exam. It's like just like Camila said, like I say I'd like to do an ultrasound. I want to look at your heart or whatever organ, and this is why, and this is what I'm looking for. And as I'm, putting gel on my transducer, I'm saying, I'm not a sonographer, I'm not a radiologist, I'm not a cardiologist. I can do some things well with this. There are other things I can't find. This isn't the same as getting a test in radiology. I can't exclude every possibility. I can miss things and I can make mistakes, just like I can with everything else. And I'm very blatantly open with them, even though I think I'm pretty good with the machine. I still make sure that they understand what the scope of this tool is. And then the unexpected finding thing is really a hard one. And the first couple of times that happened to me, I really had no idea what to say, and I fumbled through it quite a bit. But since then, I've kind of developed my own script that has worked well for me, which is basically, I almost always show them the images, right, unless they don't want to see for some reason. And I'll talk them through, like, this is your right ventricular outflow tract, your intraventricular. These are you don't use jargon, but I talk to them about what their anatomy is, and I'll say this part looks good, this part looks good, and I'll say, this here, I don't know what this is, honestly. I'm not sure what to make of this finding. This happens sometimes. And I'll just walk them through my thinking on it. Like, I think it could be this, or nothing. It's probably nothing. Most of the time what I say is it's probably nothing, because it probably is. And then this is what I think we should do about it. And people honestly really like it when they can get inside of our heads. Like, there's no less uncertainty whether I say it out loud or not, in my mind, right? And I think the patients should know that. They should be empowered to understand where we're at and what our thinking is, in the same way that I would type it. They read all of our notes anyway, and I have to express my uncertainty there. So do I want to tell them in the room, or do I want to not tell them and have them read it later that I wasn't sure what I was looking at, that's why I was ordering another test, or why I was having come back, right? I think it's super important to be transparent with that. And I would argue that when we can be open with our patients about uncertainty, they know that we are imperfect. They know we don't know everything, right? They know that we make mistakes. Pretending we don't is the best way to sabotage any trust, I would say. And admitting where we're confident, where we're not, I think also is a really important piece to building trust with our patients. So that, I guess that's my approach, is total transparency. And if I don't, honestly, in general, if I feel like I can't say something to a patient, I'm probably thinking or doing something wrong. So anyway, just as a side note.
Love that. Thank
Josh,
you so much, Josh.
no, I'm just kidding.
Go ahead. Go ahead,
I
Minna, do you have some comments from the chat?
to bring a question from Dr. Nalan Schnorr, our colleague at OHSU. Very kind of interesting question. How do we capture the real benefit in patient satisfaction without getting misled by patient reassurance or satisfaction that's not clinically helpful? So, for example, patients can often ask for unnecessary tests for reassurance, which could be harmful, like CT scans when they're not necessarily clinically indicated. Mammograms are not indicated, but ordering those tests would improve satisfaction if studied. So, and there's some evidence that return rates for screening mammography are slightly lower after an initial false positive screen. So the question is how would similar psychology play into POCUS? And if you think if there's a relationship there.
Camila, you want to start us off?
Yeah, I think we know from both POCUS but also other diagnostic tests that that patients really like having tests done, and they have a higher confidence in the GP's assessment if there's been a test as well. So I don't think this is exactly related to POCUS, and I think that is probably why we have to explore the patient perspective some more, and we have to do some interviews with patients. We have to understand what is the aspects of this patient experience when they are exposed to POCUS, and is it what is related to patient satisfaction with the POCUS exam and not only with the test. So yeah, I think we need more knowledge about that.
I think that's a really fascinating question. Yeah, any other thoughts on that, Tenping?
I think the very valid question of how to say it's just POCUS. And I think the difference between any other test and POCUS is that POCUS involves time with your doctor. And how do you separate that time from POCUS? And I think I don't know if it's ever possible, right? People want time with the doctor. That's like across the board. I see my doctor, he's in for 5 minutes and he's gone. And this doubles and triples the time. But how do you separate them from POCUS? I don't know the answer.
Yeah, on some level, I guess if I may, it's important to understand that so that we understand what we're doing. I still think the patient's being satisfied is positive. Like it's not a negative thing, right? And I don't disagree that the nuance is important, but I still think it's positive. And so, I mean, I guess I wouldn't think of that necessarily as a detractor, but maybe a less of a strengthener if it was more of the not clinically helpful. But again, isn't this all about the patient experience? Just to Tan Ping's point, one of the things that I think that I looked for in our study, which I would love to find a way to randomize this and have some folks somehow, I don't know how I would ever do that, but it would be kind of hard, but randomize people to receiving POCUS versus not and seeing what the difference was in our environment. But where we're in our clinic, we get a lot of time with patients. And again, we don't have a comparison group, but they said that this added value to their visit, and they already spent over an hour with their doctor. We were in the room. I would have to think at some point there's a ceiling effect to that time, and when we orient here, we're instructed to never interrupt people. And we always say, what else? What else? What else? Like we give people a lot of time and a lot of attention, and everybody gets a full exam. And I mean, it's really a high touch situation already. And so to see still people saying, no, this made it better. And again, I know it's not a comparison group, but to me, that argues that there may be more to it than time.
And I'll add in, I agree with Josh. I think satisfaction is a real and important benefit, but there's a lot more to be explored. And so from a research standpoint, I think implementing randomization, basically clinical trials, looking at pre-POCUS and post-POCUS, for example, degree of symptom severity, and looking at questions like, can POCUS actually improve the severity of symptoms, looking at anxiety levels and measuring mental states, and also looking at post-discharge follow-ups if we're talking about inpatient POCUS or in the outpatient setting, basically looking at what happens down the line. Do patients get more tests or do they get fewer tests? Are they admitted to the hospital more or less frequently? So I think we do have to explore other objective outcomes, but I think satisfaction is an important starting point.
All huge needs for areas of future research, definitely, Evan. And any final questions you want to bring forward from the chat? Thank you so much.
A question from our colleague in Ethiopia, Dr. Temesgen Abicho. How common is it to have patient-reported outcomes and satisfaction along the POCUS journey or in the POCUS journey? Is this research kind of being done in lots of different places, or is this very, very new to consider the patient-reported outcomes?
What do you think?
Maybe you know this since you have the pulse on these type of studies that are coming out. I mean, my understanding, and Evan, when you did the research, is that this is not a very well studied field, right?
Yeah, I can tell you from my literature review, I think the earliest data on this topic relating to POCUS really came from the emergency department, which is where a lot of POCUS really got started. And so it kind of makes sense that that's where that was one of the first places where researchers were looking at the patient experience. And then obviously talking to or hearing from Camila and Josh that there's also lots of important research in the outpatient setting, not as much in inpatient settings, but overall, this is a pretty small body of literature. And I think the majority is still coming from the emergency department.
Yeah, and I would say even that isn't super robust. There's not a ton that's even out of the emergency department. I think the first study I read on it was from emergency physicians, and it actually surveyed parents whose children, if I remember right, that was back in mid to late 2000s was the first thing I read. So yeah, agreed.
From the outpatient setting or from primary care, there are very few studies, and we are trying to work on that, of course. So what we are looking into right now is we are trying to, in a randomized trial, we're trying to see patients who have lung ultrasound, how they experience the consultation, those who have ultrasound and those who do not. And also we're trying to see in another study where we have 250 GPs performing ultrasound, we are trying to see if we can see some sort of relationship between the patient experience and the GP. So is it person related or is it because I think maybe one of the limitations with the studies that we have right now is that the GPs or the physicians who are part of the studies are a selected subgroup of physicians, and they might be particularly enthusiastic and friendly towards patients. So when we upscale and have a broader group of physicians, we might be able to see some differences.
Wonderful. Well, we are at the top of the hour. I just want to thank thank you all for joining us this morning for this incredible kind of conversation, and for our panel participants, Camilla, Josh, Tanping, Evan. Thank you for the research that you're doing and for sharing it with us. I think just to wrap up, a couple of themes that came up throughout the hour: this POCUS positive effect, a sense of trust, patient satisfaction, and also across different research groups, from the outpatient setting, hospital setting, and consultative setting. And the question, why is this? Why is there such a positive effect? Why this trust? Why this placebo effect? Is there something therapeutic? And kind of, I think, very interesting for future research. I want to just pose that perhaps this positive effect does have to do with a sense of control and a feeling of being seen and heard within this hospital therapeutic context. And so certainly more research needs to be done, and being open with uncertainty from a clinician's perspective, and also just generally more research that considers the patient perspective, across the board, not just POCUS, but really, we really should, as in the House of Medicine, be considering, of course, our patients first and foremost, and how medical care impacts not only quantitative things that we can measure, but the experience. And I'm just so grateful that you all have joined us to be in this discussion, and I hope this is a seed that's planted for future research, future conversations, and we hope you join us for our next webinar. Let us know if this is something that you want us to continue to explore in future webinars, but this is certainly a passion of all of ours, and just grateful to everyone for being present today.
Thank you so much. Thank you to our panelists. Wonderful. Camila, Josh, Evan, Temping. Have a great day, everyone.